Welcome to Interventions for Clients with Acute and Chronic Renal Failure, Part 1 lesson. Severe kidney disease leading to renal failure is common in North America. Acute kidney injury is most common in the acute care setting, and chronic kidney disease, which may take years to develop, is more common in the community. Both types of kidney dysfunction cause problems by interfering with urinary elimination and disrupting homeostasis of fluid volume, blood pressure, electrolytes, wastes, and acid-base balance. These problems can reduce general function, shorten life, and decrease quality of life. After this lesson, you will be able to compare and contrast the pathophysiology and causes of acute kidney injury and chronic kidney disease. Explain lab data related to progress of kidney disease. Discuss interventions to prevent acute kidney infections. Coordinate nursing care for the patients with end-stage kidney disease. And provide patient education on kidney transplantation. Acute kidney injury, also known as acute renal failure. Acute kidney injury can be caused by many things, such as inadequate kidney perfusion, damage to the glomeruli or interstitial tissue or the tubules, or obstruction. When the BUN and serum creatinine levels rise together with the same ratio between the two, you have renal failure. The types of acute renal failure are pre-renal, intrarenal, and post-renal. Okay, so let's discuss the pathophysiology of renal failure. It is a fluid volume excess. There will be electrolyte and acid-base abnormalities. There will be an accumulation of nitrogenous waste and hormonal inadequacies. Etiology is related to severe hypotension or dehydration, heart disease, nephrotoxic agents, DIC, uric acid crystals, transfusion reactions, sepsis, acute glomerulonephritis, vasculitis, severe hypertension, or hepatorenal syndrome of cirrhosis. 50 to 80% mortality rate. 80% are due to acute tubal necrosis and worsening of chronic renal infections. Chances of returning to normal renal function is really good if the patient can live through whatever caused the acute renal failure. So now we're going to discuss collaborative care for the acute renal failure patient. Early recognition is key. Assess for blood volume depletion, decreased urine output, postural hypotension, and tachycardia. Decreased urine-specific gravity indicates a loss of urine concentrating ability and is the earliest warning sign. You want to watch closely if two nephrotoxic drugs are used together. You will monitor for electrolyte abnormalities. Serum creatinine is increased. The BUN is increased proportionally to the serum creatinine. Sodium is normal to decreased. Potassium is increased. Phosphorus is increased. Calcium is decreased. Magnesium is increased. CO2 is decreased, and pH is decreased. So diagnostically, a KUB can be performed, an ultrasound, a CT with no contrast, and an MAG3. During the oliguric phase, there will be close monitoring for life-threatening electrolyte changes and nitrogen retention that may require intervention. During the diuretic phase, hypovolemia and electrolyte loss are the main problems. Focus is placed on fluid and electrolyte replacement and monitoring. For drug therapy, diuretics are used to increase urine output. There are fluid challenges. There may be use of dopamine, CVP monitoring, and then calcium channel blockers will prevent influx of calcium into the kidney cells, which will increase the glomerular filtration rate. Diet therapy will include specified amounts of protein, sodium, and fluids. Potassium will be restricted. Nutritional support may be needed, for an example such as TPN. And then fat emulsions may be added. And then we have renal replacement therapy. This can consist of continuous veno-venous hemofiltration, continuous veno-venous hemodiafiltration, continuous arteriovenous hemofiltration, or continuous arteriovenous hemofiltration with dialysis. During dialysis, you will watch for uremia, persistent hyperkalemia, uncompensated metabolic acidosis, fluid volume excess that is unresponsive to diuretics, uremia pericarditis, and uremic encephalopathy. For venous access dialysis, you may need for a few weeks. It's a dual or triple lumen catheters placed in the subclavian or the internal jugular vein. And then for longer term, a long-term catheter will be placed by tunneling technique, and there are 2 to 3 different lumens. Peritoneal dialysis is the use of the peritoneum as the dialysing membrane. Dialysate is infused through a catheter that is implanted into the peritoneum. Then there is the possibility of continuous renal replacement therapy and continuous arteriovenous hemofiltration. The advantage is there are no radical shifts in fluid and electrolytes in CRRT, and then CAVH is used in fluid volume overload, and it will remove large amounts of plasma, water, waste, and electrolytes, but there is a risk of bleeding. This concludes Part 1 lesson of interventions for clients with acute and chronic renal failure. If you have any questions related to the lesson content, contact the instructor.